Hello everybody, I am Dr. Debapriya and we also have with us Dr. Indrasish. So today our discussion will be on childhood headache in office practice and how much of a problem it really poses to us, the clinicians, pediatricians and pediatric neurologists alike, and how much devastating it is for the parents. So the first question which we would like to discuss is that how seriously should we take headache in children? Dr. Indrasish.
Thank you for introducing me. You see, childhood headache is one of the most common neurological complaints that we come across in OPD practice. Mostly, childhood headache complaints are usually due to less serious reasons like that associated with a viral prodrome or due to rhinosinusitis related headache, or it might be due to a stress related headache in adolescence, exam stress, or any kind of situation in the home environment where there is psychosocial stressors that can cause headache. There are other less frequent causes of headache which are require immediate diagnosis and treatment, and these are usually the other secondary causes of headache like a raised intracranial tension or a meningitis related headache, or it might be a ICSOL or a intracranial space occupying lesion related headache.
Headache might not be due to any life-threatening situation, but nevertheless, it creates distress to the parents because it affects the quality of life of the children. The child might stop going to school, might not do the activities which the child enjoys, and that is very distressful to the parents, and that's why they usually come to our clinics. The common causes which we deal, we can broadly classify it into two types, right? So one is the primary headache. Primary headache, it can be childhood migraine which can present with and without aura. What is aura? Aura is the other systemic symptoms which we see with migraine. It can be in the form of visual hallucinations, auditory hallucinations, some form of dizziness, vertiginous sensation, and it can present also with some vague discomfort, right, or some somatosensory phenomenon. And also, if we leave apart migraine, the second major cause of primary headache is tension type headache. Thirdly, we can have headache due to the inflammation of the trigeminal nerve due to some cause, which we name as trigeminal cephalgia. Leaving the primary headache apart, headache can also be due to some secondary causes. The most important ones, the most common causes are those which are due to the organs which are situated near the head or in the head. So in case of any ocular problem or any problem in the ears or any oral mucosal problem or any inflammation in the teeth, this can all, some dental infections, this can all present as headache. Also, headache can be a presentation for vascular disorders like CNS vasculitis or some post-varicella infections and all. Headache can be a sign of meningitis. It can also be a harbinger of impending psychiatric crisis. Next question which we commonly face is that can kids also have migraine? Can my kid also have migraine?
Childhood migraine is not uncommon. If you tell the estimate of childhood migraine till 18 years of age, on an average, it has been found globally the incidence of childhood migraine is 7.57 to 9.7%, which is not less, I should say. And in adolescence, this incidence increases to as high as 20%. And as early as 4 years of age, you can make a diagnosis of childhood migraine. If not migraine, migraine in children can present as pre-migraine variants like the benign paroxysmal positional vertigo, what we say in clinical medicine, and there are other forms like cyclical vomiting syndrome, which if picked up early, we can counsel the parents accordingly. Presentation of migraine in children is unlike adults. It is not like the typical unilateral throbbing or pulsatile headache that the child is able to describe. Usually the child describes the headache as typically holocranial, sometimes diffuse, sometimes mostly on the vertex. They will place the hand on the vertex and they will tell that the pain is like that from coming from there. And it usually it is not uncommon to find that it will not be accompanied with the symptoms madam told, like the aura symptoms, the visual auras or the auditory auras might not be there in childhood migraine. In adolescence, if you see, migraine has a more gender predilection towards girls.
So, taking up from Indrashish, what I would like to summarize is that we have certain stereotypes regarding migraine because till date it was mostly focused in the adolescent and adult population. What we tend to think is that migraine, it will only present with headache. It will be unilateral. It has to be around 12 to 24 hours. It will be a long-standing headache, and it will be necessarily be associated with aversion to light, aversion to sound. But here we need to focus on this point is that childhood migraine can present differently, and sometimes quite early at age it can present with certain pre-migraine syndromes. For example, what we see now, if we what we have from retrospective history taking, what we have understood is that most of the adolescents, when they present with typical migraine to us, they always give a history of some persistent infantile colic, which was not controlled with the regular medications prescribed by the pediatricians, or the child might have had some repeated episodes of vomiting for which the child required admission each month, triggered by maybe sunlight exposure, some stress, exam stress, anxiety, some family stressors, or some triggers which we don't commonly take into account, like fruits which give overly ripening odor, strong perfume, mosquito repellents,
even sunlight.
Sunlight, sleep deprivation, having chocolates, certain kind of food triggers can also be there. And in case of females, what we see is that often this pre-migraine, syndromes, they change to migraine once they have attained menarche. And during menstruation, they might have this predisposition to develop acute migraine episodes.
True.
Dr. Indrashish, please enlighten something about tension type headache, which is the next biggest primary headache category.
So tension type headache is again not a very uncommon encounter in pediatric office practice, and I in fact on some situations like in the adolescent age groups, unlike what is reported in the literature, what we usually as clinicians find is tension type headache to be more common than childhood migraine, because of mainly due to anxiety, stress related issues, or it might be due to some chronic muscle soreness or fatigue in and around the cranium can cause or trigger a tension type headache. It is usually described as a holocranial diffuse kind of headache. It can have multiple onsets and offsets in a day, like multiple recurrences in the same day, and usually it will have a predilection towards the end of the day or the evening time. And for tension type headache, what we usually recommend, if it is very unbearable or impairing the quality of life, like the child has stopped going to school or it is affecting his or her school performance, what we usually give is a low dose paracetamol or a acetaminophen kind of NSAIDs group of medications just for the acute treatment management, and we counsel for change of lifestyles and relaxation techniques work better on the situations to prevent further recurrences of such kind of tension type headaches. But tension type headaches has equal predilection in males and females, unlike childhood migraine.
When a child reaches to us with headache, they have already done an ophthalmology evaluation regarding whether they need visual aids or not. So how much do you justify? Sometimes it is done by the parents itself, right? Like 3 to 4 months back, they would have done one ophthalmology evaluation and the child might already be on visual aids. And after that, the child is not improving, then they come to our practice that it's not happening. It's not improving.
Solely due to refractory error, you mean? Refractory error of the eye. solely due to that, a child presenting with a very severe headache, impairing the quality of life, it is very uncommon clinical encounter.
Yes.
I must say. On these scenarios, what I have found in my OPD practice is headache is due to multifactorial causes.
Yeah.
Usually, refractory error being one of the contributing causes. You have to search for a cause even in that scenario after addressing the secondary causes. After putting the child on a specs for distant visual error, refractory error. After addressing the sinusitis related issues, we have to see whether even after that the child's headache is persisting or not. If it is persisting, then we have to further explore the cause and counsel accordingly. Medications, overuse of medications is contributing to the headache.
Yes.
So first you have to stop all the medications until and unless you find it deemed necessary for the headache.
In most of the cases, headache in children cannot be attributed to a single cause. It might be some primary headache associated with other secondary causes, like some deviated nasal septum. Lifestyle modifications might be needed in that case, and in some cases some breathing issues might be there. The child might have some vascular etiologies associated with it. On top of that, there might be some ophthalmological problems. It might be, often we see iron deficiency, right? It can precipitate fatigue, and that is often presented as headache. So child's headache can be attributed to multiple causes, and when we are evaluating for headache, we need to look at the child holistically, right? So after that, next the topics which we should ponder on is, what are the red flags of headache in children? And in the same take, if we will discuss, like, in which cases should we advise for a neuroimaging, because parents come and they tell us ki, doesn't my child require CT or MRI, or is it so serious that you're advising for a CT or MRI? What is your take on that?
So this is a very important question, and probably the crux of our discussion on headache, childhood headache. So on the beginning, I have said that childhood headache is usually due to less serious causes, but there are less common cases of headache, childhood headache, where the cause is very serious and needs to be addressed immediately. So by red flags, we mean to say that are the early markers which are from the clue from the history or the examination of the child or from the investigations that point towards that the headache needs to be addressed immediately. It is due to some serious cause. Basically, those headaches which are very recurring, relapsing, and very resistant headaches and very frequent headaches usually are the most serious headaches. And the red flags for those are a headache that wakes up the child from sleep in the night, a headache that is happening early morning, it is exacerbation is there on bending or coughing or straining or doing some Valsalva maneuvers, a headache that is accompanied with some other neurological signs of weakness or any kind of ptosis or extraocular muscle restriction, movement restriction. So those are very red flags for very serious kind of headaches. And the other one is if the headache is associated with systemic signs and symptoms, by meaning of that is it is associated with fever, weight loss, decreased appetite. Okay, that also is a sign of worry for the clinicians. It is a headache for the clinicians because it needs to be addressed immediately, and we have to have a proper diagnostic odyssey to address that. Neuroimaging is required in very few percentage of cases of childhood headache, but if these red flag signs are there and the headache is very resistant, recurring constantly over a period of the last 3 to 6 months, and if it is very frequent also impairing the quality of life, or in a scenario where there is a head injury followed by headache, then also neuroimaging is a must. Whatever with the constraints, even if a CT is done, will be helpful for the child.
So to encapsulate what Dr. Indrashish has said, when should headache be a red herring for a clinician? Whenever the child is awakening from sleep and complaining of headache, or getting up in middle of sleep that I'm not able to sleep, his sleep is getting disrupted due to headache, or he presents with certain signs, notably loss of consciousness, persistent vomiting, especially vomiting which does not have any sense of nausea associated with it, or with some other neurological signs like seizures, loss of extraocular movements, he's not able to move his eye, some limb weakness, or in some other signs like some dizziness is happening, some kind of hallucinations are happening, then we need to do a then it needs
Proper
to be,
workup.
yes, we need to be pep ourselves up, and we need to do a rapid investigation to find out the cause, right? And always, like in these cases, raised intracranial tension and
Has to be
the
excluded.
causes secondary to it, whether it is idiopathic or it needs something which requires immediate medical or neurosurgical intervention, should be ruled out. How to deal with headache in children? Do medications really help? How much does it help?
For acute symptoms of headache, when it is interfering with the quality of life, I mean to say the child's education, daily life activities, school going is affected, we need to give some symptomatic measures in the form of safer NSAID groups, like probably a paracetamol can help, or in adolescents we can address it with NSAID category medications like naproxen, with preferably a domperidone combination we can give. For some shorter duration like 7 to 10 days, we give the medications for the acute phase. And for preventive attack, to prevent further attacks of headache, as in my case of childhood migraine, there are many groups of medications, and probably I have found medications like that is flunarizine kind of medication, or sometimes
Triptans also.
topiramate or any prophylactic medications are needed when the attacks are very frequent, and probably it is impairing the quality of life. So headache that is impairing the quality of life needs to be addressed with some acute measures to address the acute period, and to prevent further attacks, we decide on accordingly, like whether the headache is a primary headache that is bound to recur again and again, or whether it is a secondary headache where if the cause is addressed, then we can find a cure for that headache permanent.
Yes. So here I would like to emphasize is that what we usually tell the patients to do once we have ruled out any life-threatening situation is to maintain a headache diary. Some, like, it can be maintained by parents. In case the child has insight, it can be maintained by the child also. Mostly above 6 to 7 years of age, child can themselves maintain a headache diary where the nature of the headache, the duration, any trigger, for how long it is staying, any relieving factor, these all needs to be recorded, and for like how many times the child is needing any emergency medication for that. Based on that frequency of emergency medication usage and hampering of the quality of life, we decide whether to prescribe any daily medication or not. And in case it's a like persistent condition, we always need to give them an acute treatment plan, right? And in case of secondary headaches, unless and until we treat the secondary cause, we can't relieve the child of headache. So take home message from today's session, Dr. Indrasish.
So to summarize, childhood headache is one of the most frequent neurological complaints, or a chronic neurological complaint that is affecting childhood. And since the children is our future, and especially the headache what we see frequently is in the school going age group, and it has got immense implication in form of it is affecting the education of the child, and overall it is affecting the society as a whole. So there is days of school absence, there is impairment in the quality of life, the functioning of the whole family gets affected. We have seen parents staying back at home to manage the headache of the child, so there is loss of pay also, and it causes distress to the family, including with the child included as a whole. So we need a good amount of counseling there. We need to sympathetically address the problems or the concerns of the parents. There, I think the half of your job is done, and then you, with a proper diagnostic approach, you approach the headache. You first separate it out whether you are dealing with secondary causes of headache, which if once corrected will not lead to further recurrences of the headache, or it is a primary headache. Usually in case of childhood migraine, we will find a positive history, family history, that is found in at least 70 to 80% of a suspected childhood migraine disorder. So we will search for a family history is there or not. That would further point towards the etiology, and the ultimate aim is, even if a migraine is detected or a migraine is diagnosed, we know migraine headaches can be very chronic, and sometimes it can continue to as the child grows into adulthood. So ultimate aim in those kind of scenarios like childhood migraine is to give the child the control of their own headache. We give them rescue medications when acute symptoms happen, and we also put them on a chronic preventive treatment, that is a evidence-based medicine, evidence-based latest treatment guide according to the latest treatment guidelines, so as to prevent further attacks, and see to it that every time when the child comes back for follow-up, his or her quality of life is, there is improvement or not. Headache might persist in milder, so it might go from severe to mild. We ask the child to grade how is the grading of the child headache from 1 to 10. It might go down in severity, but quality of life should be improved or should be maintained. That is the message.
I think their cognitive behavioral therapy also plays a great role.
Yeah, in cases of tension type headache or a stress related headache or a headache that is having other somatization features, which is hinting towards the impending psychiatric illness, in those scenarios we need the help of our allied healthcare specialist like a clinical psychologist can do some counseling sessions, relaxation, explain some relaxation techniques or alternative thinking approaches, or kind of a cognitive behavioral therapy approach for those kind of headaches. So apart from pharmacological treatment, these kind of measures might help.
Like that's what I have also found in my office practice, that apart from pharmacological pharmacological interventions, lifestyle modifications, they solve the case in 70% of cases.
In case of lifestyle measures, we usually speak of smart lifestyle. Smart. So S signifies that there is less of screen time. Screen time should be reduced. M signifies that you take the medications that are prescribed by your doctor. Don't overuse medicines. Don't take any alternative medications which have not got a label. Okay, and you focus on activities like more of physical exercises. Like time should be dedicated. Time should be there at least 45 minutes to 1 hour for physical exercises daily. That might reduce stress. That also helps in childhood migraine also. And there should be adequate rest, at least 8 hours of sleep, be it afternoon and a night sleep combined, or a simpler night good amount of sleep should be there. And at the same time, food habits, usually it is seen that in childhood migraine, both excess of sugar, taking intake of excess of sugar, or if you restrict sugar in your diet, then there is a aggravation of the migraine symptoms or the headache symptoms. So you tell sugar crash should be avoided. That is there.
So coming to the last segment, the take-home messages, which I would like to encapsulate in a nutshell, it's that dealing with headache in children needs empathy, and at the same time a very low suspicion for to rule out life-threatening events, especially in a country where childhood headache is taken in a very granted fashion, and over the counter medications are so much available. It needs to be dealt with empathy, compassion, but with a justified evaluation. Lifestyle modifications, they can solve the case in most of the cases in our patients, and judicial use of medications with an acute management plan for crisis is very, very important. I hope it has been an insightful discussion for the pediatricians and the parents of the children alike.